Good evening. Welcome to this special Ask the Expert event focused on advanced care planning. Tonight, a panel of experts will share helpful information for starting a conversation with your family and loved ones about your healthcare wishes. We will also answer your questions live. To submit a question for our panel, simply drop it in the chat here on Facebook. Let's meet our panelists. First, we have Dr. William Anderson, Medical Director for Mary Washington Hospice and Palliative Care. Next, we have Camille Donnelly, Director for Mary Washington Hospice, Palliative Care, and Grief Support Services. And finally, we have Terry McAuliffe, Community Liaison for Mary Washington Hospice, Palliative Care, and Grief Support Services. Dr. Anderson, I'd like to start our program with you telling our viewers a little bit about National Healthcare Decisions Day, which is this Friday. What is National Healthcare Decisions Day, and how should we be observing this day?
Thanks, Emily. National Healthcare Decisions Day was started in 2008, and it actually began right here in Virginia with a Richmond attorney named Nathan Kottkamp, who served on the ethics committees of several hospitals and found that there were frequent ethical problems concerning patients with serious illness who had not made their wishes or preferences for their care prior to a crisis, and they were not able to speak for themselves when they became seriously ill. So this was a day designated to have everyone consider that situation and try to avoid that situation with advanced care planning. But I hasten to add that there are 364 other days of the year, every year, that advanced care planning should also be done.
Thank you, Dr. Anderson. So you mentioned advanced care planning. Can you tell us a little bit about that and what it means, what it is?
Well, the first thing is to have a conversation with someone in your family or a close friend who could speak for you if you became unable to speak for yourself as a patient, and talk to them about your preferences, and with an eye toward preparing a document that will record those preferences. But it is really essential for someone to have both a person who can speak for them and the document to guide that person. You can never prepare for every single situation. So it is important to have that person who knows your values, who knows you very well. And that person goes by several designations. They're called healthcare proxies, or agents. They are called surrogates. But no matter what the term, that is the role of that person, to be able to speak for you when you cannot speak for yourself.
Thank you, Dr. Anderson. Camille, I'd like to spend some time chatting with you a little bit about why advanced care planning is so important. You know, Dr. Anderson mentioned having a medical proxy or a surrogate in place to help make decisions for you if you can't. Talk to us a little bit about when that might be needed.
Sure. Thank you, Emily. So I really think the difficult thing about when we get to situations like this is none of these things are expected. We don't expect when things are going to happen to us. And what we see very often in our healthcare realm is that there are people who now are experiencing terminal or life-limiting illnesses, and it kind of hits them head on because they haven't had these conversations. And worse, if you have a situation where the patient is unable to speak for themselves and someone is unsure of what that patient might want, then it just causes a lot of confusion. I'll never forget when I was pregnant and getting ready to have my little boy, And I started telling my husband what I would want if something happened poorly. And it wasn't that I had an untrust in the healthcare professionals taking care of me. It was just that I wanted that the first time that he heard those thoughts and those questions to come from me. And I didn't want it to come kind of in an urgent crisis. So I think that's probably the most important part to keep in mind is it is morbid. You know, it's hard to have conversations like that. But if you keep it in with the thought process of the fact that you're decreasing any confusion that could happen if unfortunate events happened, and you're really empowering your loved one to know what to say, to speak up for you. I found that a good time to have these conversations is if you have a friend or a loved one who is diagnosed with an illness or is having something, and that dialogue starts happening amongst your friends and family, just to kind of open it up. What would you want if that were the case? And I know Dr. Anderson spoke about the formal process and having a document. All of that is kind of the end result of what advanced care planning can create. But just starting the conversation is the first step that really is so important.
Thanks, Camille. So you mentioned some benefits from a patient's perspective, but Dr. Anderson, are there also benefits for medical providers to see a patient's advanced care planning?
Oh, definitely. And I think every physician should feel comfortable with these conversations, especially when a patient introduces the subject themselves. Certainly primary care doctors tend to have this conversation, but I think it has to be really patient-centered and patient-directed. We doctors have had kind of a history of paternalism, and so particularly some of our older patients may still want direction from the doctor. I think it's what I always tell people is these are personal decisions. These are not strictly medical decisions. Physicians can tell someone about prognosis or other medical facts, but you could have exactly the same set of medical facts, and two different people would have entirely different preferences. It's important to keep that front and center.
Thank you, Dr. Anderson. Terry, I'd like to talk with you a little bit about who should participate in advanced care planning. We've heard a little bit about, illness and injury, and these can affect people of all ages, all walks of life. So tell us a little bit more about your experience about who should be participating in advanced care planning.
Emily, this is a great question. What is the best time to begin a conversation about advanced care planning and completing an advanced directive? In my experience, advanced care planning is useful at any stage of life and should be developed at any time, whether you are sick or you're well. Advanced care planning is really about the what ifs that may occur across an entire lifespan. You could have a traumatic event or accident, such as, being maimed in a motorcycle accident. And that could happen to someone very young. You could be an adult at any age, and you may become sick or disabled with a progressive disease. Or you could be an older adult who may be approaching the end of life. Everyone over the age of 18 would benefit from having an advanced directive and having these conversations. We find that, and there's some lack of awareness, I guess, especially in those who may be younger in age, of the benefits of advanced care planning. And so at the age of 18, you are legally an adult. And as such, it's assumed that you're competent to make healthcare decisions and know the risks and benefits from these treatment decisions. So really, anyone over the age of 18 can and should have these important advanced care conversations with their family and their loved ones and their physicians, and they really should consider completing an advanced directive and sharing that.
That's great advice, Terry. Thank you.
And some of the most famous instances of where lack of such conversations caused a lot of pain and suffering within families have been publicized in our media over the years. It involved young women, Karen Ann Quinlan,
Yep.
Terry Schiavo, and Nancy Cruzan were the three cases that I think held everyone's attention and let us know that this could happen to anyone at any age.
That's a
Dr.
great point,
Anderson.
Dr. Anderson.
It really shifted a lot of attention to the patient's rights perspective and how patients need to have vehicles in order to communicate what they would want for their care. And those cases are really great examples of how the spotlight was shown on how important this planning can be.
Great. This is great conversation. Let's keep it going. Terry, earlier, Dr. Anderson mentioned having a medical proxy, a medical power of attorney, a surrogate, someone designated to make medical decisions for you in the event that something should happen. What advice do you have for our viewers about what factors or qualities that they should look for when selecting that person?
Some of the guidance that we would, I think, suggest would be, making sure that the person that you select to speak for you, if you're not able to speak for yourself, making sure that they're comfortable talking for you, right? Making sure they're comfortable talking to your physician, making sure that they know you well, making sure that they're calm in a crisis, making sure that they're, able to, answer questions from your friends and family if necessary. And someone who really knows your wishes. I think there's some important qualities that the person that you consider being your medical power of attorney or your healthcare agent may have. And as importantly, making sure that they make your wishes heard. Wouldn't you say, Dr. Anderson?
Yes, that they can closely question the physicians and other healthcare providers to give them accurate prognosis. I think that's very important.
One more thing I just would like to add is something that was a little bit new to me before I came to this department is kind of what the law says about who can make decisions for a patient who's unable to make them for themselves. And there are some straightforward relationships where someone's married and their spouse might make the decisions. But there are a lot of the time where there's not that straightforward person. And if there is not, like Dr. Anderson and Terry were speaking about, a surrogate to make the decision, then the expectation is that it would be a consensus of a group, such as consensus of children. And while there's nothing wrong with a group decision, a lot of the time what we see is that just becomes a very logistical difficulty. Maybe children live all over the country, all over the world. Maybe there's a child that hasn't spoken to their parents in a while. And so I would say it's been eye-opening as we have assured that the right decision maker makes decisions for the patient, how difficult that can be based upon kind of what the dynamics of a family unit are. And so I think that just highlights that having a specific person to speak is the best opportunity. And yeah, it can be the person who is the spokesperson. They can speak for the group. We want everybody's involvement, but to go out and find everyone can just prove to be difficult at times.
That's a good point, Camille. And I think if two people share that power, that can be a very unsettling situation and lead to conflicts within the family. I should add that I have, in some instances, had a close friend rather than a family member be the surrogate with everyone's consent, because those within the family did not feel comfortable making such decisions or serving as surrogate. So it really can be anyone. Camille mentioned a list of relationships in Virginia law, and there is such a list, but always at the top of that list is the designated healthcare proxy or surrogate.
Thank you. So we've been talking a lot about, this process and this paperwork, and it probably sounds a little daunting to people out in our audience. So Terry, can you talk a little bit about the logistics of advanced care planning? Is there a cost? Should people look at retaining an attorney to help them with this process?
Yeah, so advanced care planning is a process, right? And it typically starts with a conversation with your family and your loved ones or with your physician. And typically after that conversation happens, we would hope that you would record or you document that conversation. That's an important part of the process. So the form where you document your plan or your wishes is called an advance directive. And that advance directive tells people what you want them to do and who should be involved in making those choices. Advance directives need to be in writing. So some states require an attorney to be involved. Virginia does not require an attorney to be involved. An advance directive in the Commonwealth of Virginia is a free, legally binding document. It is not required to be on an official form. You could write it on the back of an envelope. It's legally binding if you are 18 years of age, if you sign it, if you date it, and you have 2 witnesses. In the Commonwealth of Virginia, it does not need to be notarized. Now, even though you can record your wishes or create an advance directive on the back of an envelope, like the example I used earlier, there are free advance directive forms available and are recommended, right, to use. And the 2 most common that I've seen are the Virginia Advanced Medical Directive Form and the 5 wishes. And both of those forms you can find on Mary Washington Healthcare's website, on our hospice website, on the Virginia Department of Health's website, on the 5 Wishes website, on National Healthcare Decisions Day website. So they're readily available to the public. And if you need help with obtaining one, please feel free to reach out to any one of us on the panel as well.
Thank you, Terry. I think that you probably just gave a lot of people a sigh of relief, knowing that they don't need to retain an attorney and that it's as simple as recording your wishes on a piece of paper and having 2 witnesses to it.
Yeah.
So as you can imagine, we get a lot of questions from our community on this topic. And especially one thing that's top of mind right now is, of course, the COVID-19 pandemic. And Dr. Anderson, I'm sure that there are several people watching tonight who have unfortunately lost someone during this ongoing pandemic. In your experience, what has COVID-19 taught us about advanced care planning?
It has taught us that the appropriate time to do it is always now. The opposite of advanced care planning is emergency care planning. And that's what we've been reduced to a great extent during the COVID pandemic under severe, very stressful circumstances. So if there is uncertainty about a patient's wishes combined with time pressure, that's what COVID has brought us. And I've heard so many people say, both healthcare providers and patients and families, that we cannot forget this, that we need to be prepared if such a situation should occur again. The particularly painful thing about the pandemic has been how it has separated patients from their families. We can use telemedicine to some extent, but it's not the same as being there. So now is the time, and as we're coming out of the pandemic with increasing numbers of patients being vaccinated. We can't put this in the rearview mirror without taking steps to prevent this stress from happening again. There's enough stress with the pandemic in and of itself. We don't need to add to it.
That's
Just
a great
like we
point.
were
And I see
speaking a
Terry
little
and
bit-
Camille nodding vigorously.
Yes, yes. And just like we were speaking a little earlier about who your surrogate was or would be in getting the right people involved, another thing that the pandemic really kind of brought to light is we then had all of these rules of social distancing and being safe with our visitor policy within our healthcare system. So now we had patients who could not have visitors because of the pandemic, being in the midst of the spread and without wishes. Just to Dr. Anderson's point, now we had to make these emergent decisions and separately, not together, the patients in the hospital, the family members at home. And so I think exactly what Dr. Anderson said, which is now is the time to really make your decisions known. And Terry referred to the 5 wishes, which is a resource that you can use in a template. And I think one thing I would just like to say about it is it's very simple and straightforward, and it helps you guide those conversations. You know, it's never easy to strike up a conversation about advanced care planning. But if you have a resource that would help guide you through it, I think that is what is important. And in any situation where you are met with a new prognosis, a new disability, a lot of stuff comes along with that, fear and anxiety. You're thinking, you know, there's just so much that is happening, but the last thing that you want is to add something else to it, like making these difficult decisions without knowing what your loved one would want.
And I think it's particularly important for those who know that they don't want very aggressive, invasive care at the end of life to go through advanced care planning, because in the absence of their stated preferences, aggressive care is what tends to occur.
And during the pandemic, one of the things that I think many of us have experienced is, we feel like we've lost a sense of control over what's happening to us. And advanced care planning really helps you have a greater sense of control over what might happen in the future, because you've taken those measures and you've talked to your family and your physician and your loved ones about, would you want to go to the hospital? And if you do, and you arrive at the hospital and your loved one can't be with you, what do you want to make sure is done or not done, right? When you're there. And I know, working for Mary Washington Healthcare for 8 years now, one of the things I love the most is one of our goals is to honor your value and belief systems. And advanced care planning really helps us do that. And I think having that sense of control over our healthcare decisions, especially during this pandemic, would be so much more helpful to so many more people in our community.
One other thing that COVID-19 has shown us is how important the care setting is. We know that most people, once they get a serious illness, they want to be at home as much as possible. And since COVID-19 preferentially affected the elderly, we have seen the incidence of delirium increase in patients who are hospitalized, and this may have and certainly was present in people who probably didn't want to go to the hospital but had not voiced that concern. It's more likely to happen in a setting such as the hospital, and particularly in the ICU, where the most aggressive care is delivered. So that's something to think about as part of your advanced care planning process. Where would you want to be cared for with a serious illness?
This is Excellent discussion. Thank you so much. We do have some other questions from folks in our community. We've heard from people, getting ready to get their advanced care plan together. Dr. Anderson, they're wondering if they should involve their doctor in that conversation. And also, does a person's physician need a copy of their advanced care plan?
To address the second question first, absolutely. It's probably approaching 50% of advanced directives that are actually written, the doctor does not have a copy. That's an almost unbelievable statistic to me, but it's true. So yes, make multiple copies. Every family member should have one, and the doctor should have one as well. I will say, kind of restating what I said before, that this process involves personal decisions. The doctor does not need to drive that conversation. I think the doctor should be a resource about medical facts and prognosis, and that's always useful in these discussions, but it should never be a cause for delay of those discussions.
Thank you. Terry, we have a question here that I think matches your expertise perfectly. What steps does someone need to take, or do you recommend they take to get started with their advanced care planning? For example, if, like Camille told us earlier, when she was getting ready to have a baby, she started making a plan. If someone is looking at a recent diagnosis, like cancer, for example, what should those folks do today to get started?
Well, yeah, advanced care planning conversations, I think Camille mentioned this earlier, are empowering, right? They give us power. And so we can't plan for everything, but we can talk about what is most important in our lives and in our healthcare to those who matter most to us in our lives. So I think a first step in the process is really gathering your thoughts, taking some time for reflection, thinking about what matters most to you and what matters most to you through the end of your life, being able to recognize your children, being able to remain independent, what's important to you. And then I think another step after you gather your thoughts is to plan a conversation with your loved ones, your friends, with your healthcare providers. And that's kind of entailing when do you want to have the conversation? Who do you want to include in the conversation? And what do you want to make sure that you say? And then after you've had the initial conversation, keep talking, right? Keep talking. Our experiences and our circumstances throughout our lives change. And so this is a conversation that we should keep on revisiting. It's really easy to update your advanced directive. It's a free, legal document. So, that barrier really isn't there to easily create a new one. I think it's important when all of that is done to then record the conversation with an advanced directive. And I think we've talked about there are 2 points to an advanced directive. There are 2 parts to an advanced directive. The first part is, assigning your medical power of attorney or your healthcare agent. And the second part is your living will part, which you address what types of medical treatments you may or may not want. For example, if you would want CPR, or if you would, let's say your kidneys fail, would you want dialysis? Would you want artificial hydration or nutrition, things like that? And I like to point out that with a living will section of your advanced directive, that's different than a last will and testament. Some people get that confused. So a last will and testament kind of dictates and decides who may get your property or your assets or your finance. It's centering on finances. The living will section of an advanced directive, it's about the medical types of healthcare decisions that you want to make. It's not about finances. And then I would say, make sure that when you create this document, when you share this document, like Dr. Anderson said, have it accessible. And one thing that, you can do is bring it to us at Mary Washington Healthcare. We can scan it into your medical record and it's already there, right? Bring it into your physician and provide it to your physician and share it with your family. Take action. The conversation project, is a national movement to help encourage these conversations. And on their website, they have a wonderful starter kit that helps people begin and continue these conversations.
Thanks, Terry. I love that you mentioned the Conversation Project because I see a question here that I think Camille can add to with her expertise about initiating that conversation with friends and family and loved ones. Camille, from your experience, what are some ways to break the ice on this kind of heavy subject?
It is a heavy subject, and I don't know if I have good tips and tricks to do that, except for just do it. Just say, you know, and you can even acknowledge this is going to be hard to talk about, but I just want to go ahead and start having this conversation. Just like Terry mentioned, the Conversation Project, there are so many resources out there at our fingertips online that will help guide that conversation. But the other method that I like to use is if you know, if we're discussing, like I said, an acquaintance or a family or friend that had something, you know, bad happen to them, I think that's the time to really say, you know, if something happened like that to you, have you ever thought about what you would want? Have you ever thought about, if you were in that position, what would be some of your wishes? So I think just taking the opportunity to do it, it's just not something that really makes sense to delay. Although I think we identify that we don't think it's going to happen to us, that we're not going to be able to speak for ourselves, but that it can definitely happen. We see it every day. Terry, I did appreciate how you were saying that it's something that can be easily changed. You know, somebody who maybe is young and has more life to live might have a different type of wish that they might then reassess as they get older or start having different medical conditions. So there's nothing wrong with starting it and then changing it later. Until you are unable to speak for yourself, you're your own advocate, and that's where everyone is going to support. But like Dr. Anderson said previously, if you don't have that directive and you don't have those wishes, then the default is going to be to continue to do all sorts of aggressive measures, just assuming that's what somebody's wish was. I just want to piggyback off what Dr. Anderson was saying about COVID. I'm from Alabama originally, and one of my family members came down with COVID and is elderly and pretty frail. And so my family called to ask what they should do. Should they take her to the hospital? And so I said, well, let me talk to her. And so I said, what do you want? You know, if this goes bad, what do you want? And we were able to talk. She did not want to go to the hospital. She did not want to be intubated. She didn't, she wanted to stay home. And I believe, to Dr. Anderson's point, I believe we were able to keep her from that kind of hospital-based delirium, being able to stay home. But in my mind, what that did is it now gave us a sense of ownership of what she wanted. And if we would not have had that conversation, we just would have sat around guessing what would be the right thing to do. And often when you feel helpless and you want to help, you just send the person to the hospital. But if that's truly not what their wish is, then you're kind of just going against that. So I thought that was very much empowering. To Terry's point, within COVID, we really lost control. So for someone to be able to say, nope, don't take me to the hospital, it just was helpful to guide what the next steps were for her.
Thank you, Camille. That's great information for our audience to take away from tonight's event. We do have several questions from our community in the live Q&A as well, so I'd love to share those with you. One question for Dr. Anderson. Some folks in our audience are wondering if you can give us a quick tutorial or a primer on the difference between hospice and palliative care.
I think we may have a diagram. If you can share that. Basically, you can think of, here we go. So think of palliative care as a kind of transition between disease-directed care, also aggressive care, and hospice care. So if you look at the top part of this diagram, that's the old paradigm where it was very aggressive care right to the point of, almost to the point of hospice care. And the hospice is usually defined as the care that someone receives truly at the end of life, in the last 6 months of life. Sometimes that's difficult to determine if the prognosis is truly 6 months, but we can get pretty close. And then if you look at that little wedge, that's how palliative care started out years ago, let's say around 2000 or in the 1990s. And palliative care started out as inpatient programs exclusively, and later expanded to include outpatient palliative care as well. So if you look at the new paradigm down at the bottom, palliative care can start as soon as a serious illness is diagnosed, whether that's cancer, chronic obstructive pulmonary disease, heart failure, dementia. Palliative care is appropriate right at the beginning of any of those disease processes. And you see here, as time goes on, the care is less disease-directed care and more palliative care. A synonym for palliative is supportive, care that is directed at symptoms rather than disease processes. And so in palliative care, what I like to say is the patient's the expert, the families are subsidiary experts, because all of them know best what the symptoms are, what the sources of suffering are. And then palliative care, you see in the bottom diagram, the hospice section of the graph is expanded because with palliative care, there's earlier transition to hospice care, which involves a higher level of support by a whole team of people. So that's another benefit of palliative care. Part and parcel of hospice care is bereavement, which is certainly not part of the disease-directed care model. And it tends to be less of the palliative care model, although that could be a part of palliative care as well. And bereavement is very, very important in hospice care. Really, we treat the family as a whole, not just the patient. The founder of hospice, Cicely Saunders, who started St. Christopher's Hospice in London in 1967, spoke of what she called total pain, which was physical pain, psychological pain, social pain, and existential pain. And so hospice is about way more than just the physical pain.
That's a great explanation of this type of care, Dr. Anderson. Thank you so much.
The diagram helps a lot. Thank you.
It does. All right, we do have another question in the live Q&A from our audience. So we talked a little bit about how an advanced care plan is sort of a living document. It can be changed to match our changing lives and our changing feelings about the care that we would like to receive and who we'd like to make those decisions for us. But some of the folks in our audience recognize that medicine is always changing and it's always improving. And so some aspects of an advanced care plan that they set in place today might become outmoded. There might be new treatment options or other therapies available, other options available for care in the future. And so how can our audience members adapt their choices accordingly? What recommendations do you have? Dr. Anderson, I think that's probably a great question for you.
Sure. I think that is really best addressed through the surrogate, because you cannot really anticipate every single scenario. And I think what a surrogate or a patient would want from a healthcare provider under those circumstances is, how will a particular treatment help me? For every treatment, for every procedure, there is a potential risk and a potential benefit. And so it's kind of a balancing act that may change over time. For example, what's the likelihood that someone will benefit from CPR, that it will actually extend their life without without adversely affecting the quality of their life? And now there are actual scales that we can use to get a better answer. I mean, people want the most specific information that they can get. So we know with certain combinations of illness, there's less than a 1% chance that CPR will be beneficial. And there can always be suffering that occurs with CPR, fractured ribs. Usually there's loss of consciousness, so that would be very brief, but it could be intense suffering for a very short period of time. And also, I think many people are not aware of the fact that in the CPR process, because it's not quite the same as the circulation delivered by a normally functioning heart, there can be strokes that occur, and frequently are, during CPR. And that's something that a lot of people, that changes a CPR decision for a lot of people, because they do not want to have their quality of life impaired that way, especially if the chances of success, let's say leaving the hospital with the same neurologic function with which they entered the hospital, if the chances of that are very low.
And
I would like, sorry, Terry. I was just going to say real quick, I think it's important, like Dr. Anderson said, you can't, to get bogged down in every treatment option that you may or may not choose would probably just be overwhelming. So to keep it simple, just really focus on who you would want to make your decisions for you, as well as maybe the broader categories. Like Dr. Anderson was saying, would you want this type of life support, artificial nutrition, life-saving measures like dialysis? Those are, to me, are the things that, the broader categories that will kind of help guide your conversation, and also communicate to your surrogate what your feelings would be about any intervention opportunity.
Yeah, and in my experience, it's been helpful to remember when I'm out there talking to people about advanced care planning and I hear their stories and they share their stories with me, is when they keep in mind what matters most to them. And they make decisions why or why not this medical treatment or this, location for care. They use that idea of what matters most to me, because I've heard people say, well, if I can no longer watch the gnats and eat a hot dog, then I don't want that treatment. And that's a what matters most to them type of statement. One of the most beautiful things I ever witnessed was when a person was completing their advanced directive using the 5 wishes. And one of the questions in the 5 wishes booklet was, what do you want your loved ones to know? And there was an elderly lady and she wrote down, or she asked for me to help her write down, please let my granddaughter know that I forgive her. And that's healthcare too, right? Because it's helping her heal before it was time for her to maybe not be with us much longer. So these are the things that I think help, no matter how many technologies may change or pharmaceuticals may be advanced. I think keeping in mind what matters most to you and why not when you're making these decisions can be helpful in guiding you.
This is great guidance, guys. Thank you so much. And Terry, you got to warn us next time before you drop a sentimental story like that. That's incredible. Well, we are coming up at the top of our time, and I can see that we're getting a lot of comments from our viewers, thanking you, our panel, for your expertise tonight, and just mentioning that this has been so valuable for them. So we'll start by closing tonight, first by thanking our panelists again so much for sharing your time and your expertise. And of course, I'd be remiss if we didn't also thank you, our viewers, for tuning in to Ask the Experts. If you have any questions about National Healthcare Decisions Day or need support in starting a conversation about advanced care planning, we invite you to visit our website for additional resources. You can find us online at hospice.mwhc.com. That's hospice.mwhc.com. And of course, you can watch the Mary Washington Healthcare Facebook page and other social media to stay informed of the latest health and wellness information for our community. Thank you again for tuning in this evening. Please stay safe and healthy, and have a good night.
Thank you.
Thank you.
Thank you.